Hello YouTube, I am Dr. Rabiul. I work as a lecturer of pathology in a medical college hospital and I am making this video for my students. Hope someone finds this helpful. Okay, now today's topic is Iron Deficiency Anemia. So what is Iron Deficiency Anemia? To understand this topic, I will divide this video into two sections. In the first section, we will discuss briefly about anemia, and then in the second section, we will discuss about iron and mainly iron metabolism. Once we have discussed these two sections, then we will be ready to proceed further, and then we will discuss about the common causes of iron deficiency anemia, followed by the common clinical features, lab diagnosis and treatment. Okay, so let's begin. So what is iron deficiency anemia? First question, what is anemia? So as written in your textbook, you will see anemia is a condition that is present when blood hemoglobin level is below the lower limit or below the lower extreme of the normal range of hemoglobin for the age and sex of the individual. Okay, so I am repeating the definition again. Anemia is a condition that is present when blood hemoglobin level is below the lower limit or lower extreme of the normal range for the age and sex of the individual. Okay, now the last line where I said for the age and sex of the individual, that is important. Let me explain. Always remember the normal level of hemoglobin in adult male is 13 to 18 gram per deciliter. That's the normal hemoglobin level in male, adult male. And the normal hemoglobin level in adult female is 11.5 to 15 gram per deal on an average. Okay, so that's in female. So look at the lower limit. The lower limit for male is 13 gram per deciliter and the lower limit for female is 11.5. Okay, so if a patient came to you and you saw that that patient's hemoglobin level was 11.5, then if that patient was a male patient, then you would have said surely that patient has anemia, although mild anemia, but anemia. But if that same patient or if another patient came with the same level of hemoglobin, that is 11.5, but that was a female patient, then you surely would have said that that patient is not anemic, because that is the lower limit, not below the lower limit. Okay, so always keep that thing in mind. Okay, so now that we have cleared the definition of anemia, now we can define iron deficiency anemia. Iron deficiency anemia develops when iron level in our body is insufficient for the sufficient amount of hemoglobin synthesis. Okay, so to understand iron deficiency anemia, now we have to go to the second segment of this video where we will discuss briefly about iron and iron metabolism. Okay, so this is important. What is the role of iron in our body? Remember, this is a very high yield information. Iron is important for our body, but too much iron is bad. Too much iron, which is a term known as hemochromatosis, that is not good for us. So how much iron is there inside our body? Always remember the total amount of iron present in an adult person on an average is 3 to 5 gram Now remember, this is an average range. The range will vary, like I said before, with the age and sex of the individual. Iron level is normally slightly higher in male compared to female. Okay. Now, out of these 3 to 5 gram iron, 60 to 70% of that iron is inside hemoglobin, which is inside the red blood cells, right? So 60 to 70% of the iron in our body is inside the hemoglobin of the red blood cell. And after 120 days, when the RBC dies, what happens? RBC releases that hemoglobin, and then the hemoglobin gets further broken down into heme, globin, and ultimately further broken down into iron, and that iron binds with transferrin, a transport molecule present inside the blood, and then that goes to the either in the bone marrow to make RBC, to make hemoglobin again, or that can be stored. Okay, so that is the iron that is known as heme iron. Okay, the iron that was inside the hemoglobin in our body is known as heme iron. Okay, so then what is the remaining 30% iron? The 30% iron that is not used to make hemoglobin is known as tissue iron. Okay, like I said, iron in our body, it has two forms, some inside the hemoglobin, that is the majority, 60 to 70%, and the remaining 30% is in the tissue, which is known as tissue iron. Okay, now tissue iron is again of two types. One type is known as available storage iron. Okay, that means the iron which is stored in these tissues that can be reutilized to make hemoglobin again. And there is another type of tissue iron which is known as non-available iron. That means that storage iron or that tissue iron cannot be used to make hemoglobin. Okay, so actually those non-available irons are used to make myoglobin that's present inside the muscle, and also to make some enzymes like catalase, cytochrome, and so on. Okay, so that was a brief discussion about the iron distribution, and I think you are now getting an idea that iron is important not only to make hemoglobin, but also it has other roles in the tissue, both in the form of available and non-available storage iron. Okay, so now that we have cleared the distribution of iron, now we have to know a thing or two about iron metabolism. Okay, this is important. In order to understand iron deficiency anemia, we have to know what happens when we take food that contains iron. So as you can see, I have already drawn a picture in the board, and this is how iron gets absorbed. So initially iron, we take iron through diet. There are different types of food that contains iron. For example, iron is present inside meat, mainly in the liver, kidney. Egg yolk also contains iron. Even milk has a small amount of iron. So those are iron that we get from animal source. And we can also get iron from plant source. Green vegetables, they also contain iron. So what happens after we have taken those food containing iron? In the stomach, our acid and some other substances breaks down those particles, and iron is released from those food. But initially the iron, almost all of the iron, was in the ferric Fe3+ form. So what happens then? Vitamin C converts this ferric iron into the ferrous iron. Okay, and then that thing is absorbed by the lining epithelium of the lumen of the gastrointestinal tract. As you can see, this is the lumen of a GIT. These are the epithelium which lines the lumen of the gastrointestinal tract, and they are taking this iron. Okay, and also remember we have an important protein here which is known as HFE protein that has a key role in absorption of this ferrous iron inside the lining epithelium of the gastrointestinal tract. Now this is important. After the ferrous iron is absorbed in the lumen, what will happen? Two things will happen. Most of the iron will be stored inside the lining epithelial cell itself. Yeah, so it will be stored by binding with a protein which is known as apoferritin, and they will make a substance known as ferritin. Okay, and that will remain inside the lining epithelial cell. It will not go to the blood. Another thing will happen. Part of this ferrous 2 ion will go to the other side of the cell and go inside the blood. And remember, I had said before, iron is toxic, you know. Iron, look at the picture. Iron is always bound to something, you know. Like inside the lining epithelial cell, it is bound to a protein and it made ferritin. Similarly, in the blood, we are not leaving iron alone, you know. It's not like sodium, potassium. Iron will make insoluble salt, and that will cause a lot of problems. So we are always keeping iron with something else, bound to something else. Okay, so here you can see iron, once it goes in the blood, it's again converted to the ferric form, and now it's bound to a transport protein known as transferrin. Okay, now what will happen? Then this transport protein, okay, that will transfer iron to different places. One of the places where iron will go is in the bone marrow. Okay, why? Because we know in the bone marrow, that is the place where all blood cells are made, and when we are making red blood cell will need hemoglobin inside them, and hemoglobin is a molecule that has 2 components. One is heme and one is globin, and the heme portion needs iron. Can you recall there was a reaction, you know, the iron in Fe2 plus binding with protoporphyrin and making heme, and there was an important enzyme, ferrochelatase, required in that step. Yeah? Okay, so I'm not going in the biochemistry books now, so let's stay in the pathology subject. So that is the way iron will be transported in the bone marrow for red blood cell synthesis. Okay, so they will make red blood cell. Another thing may happen. From the blood, iron bound to the transport protein may go to a storage site. Okay, so can you tell me what are the sites where iron is stored? Iron is stored in different tissues, but mainly in the liver. Yeah, and also in some other tissues like in the reticuloendothelial system. So in those places, iron will be stored in Fe3 plus form, again bound to a protein, and we will also call those storage iron complex ferritin or hemosiderin. Okay, so in the tissue, iron can be stored in 2 ways. Both of them contains iron in ferric Fe3 plus form, but their names are different. One is ferritin and one is known as hemosiderin. Okay, so let's first discuss about ferritin. Ferritin is a colorless compound. It's very fine, so not usually visible under microscope, but when there is large amount of ferritin or large amount of iron or iron overload, then we can see a bluish tint if we can stain the tissue with ferrocyanide method. Now remember this thing for your multiple choice questions. Yeah, in the question stem you may be given hints like the particle gave bluish tint when stained with ferrocyanide method. That is just telling you that that particle is ferritin. Okay, now this is more important. Another storage form of iron is hemosiderin. and this one has color. It's not colorless like the ferritin molecule. And the color in some of your textbooks, you will see it is golden yellow, and in some of the textbooks it's written brown. Okay, so try to imagine a color in between them if you get confused. So golden yellow or brown color is the color of hemosiderin when we are staining that thing with H and E stain. That means hematoxylin and eosin stain. Okay, and we can also stain hemosiderin in another method, that is potassium ferrocyanide stain. In that case it will be similar to the stain of the ferritin, and that will be blue in color. Okay, so this is in short about iron metabolism. You may be asking, why are we storing iron in two form? Actually, in lots of your textbook you may find that hemosiderin is actually nothing but older ferritin. Yeah, ferritin has a capacity to store iron. You know, it's a huge capacity, more than 4,000, in some books 4,300 molecules of iron can be stored inside one molecule of ferritin. Yeah, so hemosiderin is the older version of ferritin that has more capability of storing iron. Okay, and it's formed by precipitation of this ferritin molecule. And you know, I had mentioned a protein, you know, when I was discussing about iron absorption. Can you recall? In the lumen we had ferric ion that was converted to ferrous ion by vitamin C or ascorbic acid, and then that thing came inside the cell, the lining epithelial cells, but there was a protein involved, HFE protein. And sometimes there may be mutation in this protein. Okay, and when there is mutation in this HFE protein's gene, then there will be some defective HFE protein in these lining epithelial cells, and what will happen? They will absorb more amount of iron. Okay, and that is not good. Always remember, in our body, iron has no well-defined method of excretion. We can excrete various waste products, you know, for example, in the form of urea, creatinine, but for iron, we have no well-developed way of excreting that iron. You know, that's why iron absorption is very tightly regulated by these cells, and that regulation in fact is done by this HFE protein. You know, so when our lining epithelial cells detect that there is less iron inside the body, they absorb more iron, and when they detect there is sufficient amount of iron, they absorb less. And usually what happens, even though they're absorbing iron, this lining epithelial cell, like I said before, one part is stored inside them. So what's happening to this part, that is this part of the iron that is stored inside this epithelial cell? Remember, after 2 to 3 days, these lining epithelial cells have a very short lifespan, so after 2 to 3 days they die, and then they are sloughed out from the lining epithelium, and then they just pass out with the stool. So that is the only way iron is excreted from our body, and there are some other minor ways, for example when hair loss or through bleeding. So those are minor way of excreting iron. So that's why iron absorption is tightly regulated, and that's why if there is mutation in the HFE gene, iron overload will occur, and then we will see iron depositing in different tissues, which is known as hemosiderosis, and that will lead to failure of those tissues in chronic cases. Okay. So now that we have discussed the definition of anemia, definition of iron deficiency anemia, role of iron, source of iron, absorption, storage and metabolism of iron, now we are ready to know what causes iron deficiency anemia. Okay, so basically in your textbook you will see iron deficiency anemia has three mechanisms. The first mechanism is increased physiological demand. Okay, so what do you mean by that? Increased physiological demand mainly occurs in two cases physiologically. Okay, one is during childhood. Okay, so remember, children grow faster than adults, right? Especially from 6 to 24 months. This time a child grows very rapidly, and when a child is growing very rapidly, his blood cells are also growing rapidly. He needs more and more red blood cell, and he needs more and more hemoglobin inside those red blood cells. So that means we're having an increased demand for iron. Okay, so that can lead to iron deficiency if the baby had less store of iron to begin with. Okay, another cause, another example of increased demand is during the reproductive life in case of female. Okay, so the first cause of iron deficiency anemia is increased demand of iron. That can occur in children, especially from 6 to 24 months, and that can occur in women in their reproductive ages. Why? Because there is a lot of reasons. One reason is menstruation. You know, in every menstrual cycle, females are losing certain amount of blood and also certain amount of iron inside the blood. So that's one thing. Another thing is when a female of reproductive age gets pregnant, there is increased demand of iron, because now not only now she has to make iron for herself, but also she has to make iron that will be used as fetal blood, you know. So there is an increased demand in case of pregnancy. And also during childbirth, a lot of blood is lost when we are cutting the cord, you know. So that's another reason. And the fourth reason why we get increased demand of iron in women of childbearing age is lactation. You know, although breast milk contains small amount of iron, but still, since breast milk has small amount of iron needed, so there is increased demand for iron. Okay, so that is the first cause of iron deficiency anemia, which was increased demand for iron that occurs in children of growing age and in pregnant mother. Okay, now the second cause of iron deficiency anemia is pathological blood loss. Okay, this is important. So the second point is pathological blood loss. Now, can you tell me some causes of pathological blood loss? Well, there are a lot of causes of pathological blood loss. Let's begin with the common ones, you know. If a patient has a bleeding peptic ulcer, he had a peptic ulcer and now that's bleeding, then there will be blood loss, right? Okay, then if a patient had hemorrhoid, you know, he will have pathological blood loss. And there are a lot of tumors or carcinoma, especially carcinoma of stomach, carcinoma of colon, which can cause bleeding from the gastrointestinal tract. So those are also caused. In developing country, hookworm infestation is an important cause of pathological blood loss, you know, because those worms go into your body, penetrating the skin of your foot, and they feed on your blood. So that is another example of pathological blood loss. Regarding esophageal varices, I'm sure you have heard the term. Here we know in the esophagus we have some portocaval anastomosis, portosystemic anastomosis, and what happens is those veins can get dilated, and sometimes those dilated veins, which are known as variceal veins, they rupture, and then there is bleeding, and that can lead to pathological blood loss. Okay, so remember, iron deficiency anemia is almost always due to secondary causes, So when a patient comes to you, say for example a male or a female after menopause, so they have no chance of losing blood through menstruation, or through parturition. So if those type of patient comes to your clinic, male or female after menopause and showing signs symptoms of iron deficiency anemia, then you have to be cautious, because they may have those problems of pathological blood loss. So I'm repeating the cause again. They were bleeding peptic ulcer, then there was hemorrhoid, hiatal hernia, carcinoma of the stomach, carcinoma of the colon, and then there was hookworm infestation, ulcerative colitis. And always remember, sometimes chronic aspirin ingestion can lead to pathological blood loss as well. Okay, so that was the second cause of iron deficiency anemia. Now, what was the third cause? So the third cause of iron deficiency anemia is inadequate intake due to either impaired absorption or decreased nutritional status. Okay, so the third cause is inadequate intake. Okay, so this is again further divided into two groups. One is due to impaired absorption, and one is due to nutritional deficiency. Okay, so why will someone have impaired absorption? If he has some gastrointestinal disease, say for example celiac disease, then there will be some problem in the intestinal villi, and that patient will have problem in not only absorbing iron but also a lot of other foodstuffs. So that's one cause of impaired absorption, that is celiac disease. Again, another cause, if the patient had any surgery of the gastrointestinal tract, say for example he had partial gastrectomy or other surgery. So if a patient had partial gastrectomy, that means part of his stomach has been cut out, what happens? The remaining stomach has a reduced capability of producing hydrochloric acid, and as I had mentioned earlier, hydrochloric acid is important because that breaks down the food particle and releases the ferric ion from the food that contains iron. Okay, another thing may happen if the patient had any surgery of his intestine, and say for example part of his intestine was cut off and then there was anastomosis made. So that is decreasing the length of the intestine, right? And as we know, if a bowel stays for shorter duration inside the intestine, there will be less absorption. So that will also lead to impaired absorption. Regarding the second cause of inadequate intake, that is nutritional deficiency, this is mainly seen in developing country, and also seen in children. Okay, in developing country, people are not always able to get the iron-rich foods, so they are not taking meat, they are not taking eggs, they are relying on the plant source of iron, and there is a problem with the plant source of iron. Remember, iron that we can obtain from plant source, that means the non-heme iron, their absorption from the lumen of the intestine is not constant. The non-heme iron that we can obtain from plant source, their absorption in the lumen of the intestine depends on other foods or other content of the bowel. Okay, so let me explain. There are some component of food that promote absorption of non-heme iron from our intestine. Those are citric acid, sugar, and some other things. And there are some components that inhibit or reduce the absorption of non-heme iron from our intestine. You know, one component is found in tea, that is known as tannin, that can reduce absorption of iron, non-heme iron, from the intestine. Another component is phosphate. So diet that contains phosphate, you know, say for example different types of cereals, they can form salt of iron, and that is not absorbed from the GIT lumen. So like I said, people in the developing country or people from poor, not all people of developing country, you have to remember people of low socio-economical status, they are unable to obtain iron from animal source, and they are having difficulty in absorption of non-heme iron due to lack of knowledge about the relationship of non-heme iron and other foods. Okay, so these are the main three causes of iron deficiency anemia. So now that we have discussed the etiology, the causes of iron deficiency anemia, now we will discuss the clinical features. Okay, so what will be the clinical feature of iron deficiency anemia? Well, one feature is already given to you, anemia. Yes, so clinical feature, the first clinical feature is anemia. And you know, you will see the normal, as usual, clinical features of anemia. The patient will be pale, you know, you have to see anemia in the patient, and there will be the usual complaints. The patient will be weak, the patient will have weakness, fatigue, sometimes even dyspnea on exertion. Okay, rarely there may be palpitation, angina, etc., and sometimes there may be menstrual problems as well. So those are the clinical features regarding anemia. There will be another clinical feature, and this clinical feature is epithelial tissue change. So this is not a common clinical feature, and this is usually seen in adult, and also not very common, but also even though you have to remember this thing. So what will be the epithelial tissue clinical features? Okay, so there will be some abnormality in the patient's nails, in his hair, in his tongue, mouth, and so on, and also in the esophagus. Okay, so what will be happening in his nails? His nails will become thin. It will lose its normal shiny appearance. It will become something called lusterless and brittle. It will be very prone to breaking down, and there will be some longitudinal ridges in the patient's nail. If this was a nail of the patient, there will be longitudinal ridges like this of the patient's nail, and that nail will become flat, and sometimes in severe iron deficiency anemia it may become totally spoon shaped, which is known as koilonychia. So epithelial First we talked about the nail. Okay, what will happen to the patient's mouth? There may be angular stomatitis. That means there will be some ulceration like a feature in the angle of the patient's mouth. Okay, and what else? There will be some problem in the patient's tongue. What will happen in the patient's tongue? There will be atrophy. Okay, so there will be atrophy of the papilla of the tongue, and the tongue will become shiny, which is not a good thing. Tongue is good when the tongue appears rough. It has different types of papilla for different types of sensation. So when those papillas are lost, the tongue will appear shiny, and there will be atrophy of the papilla of the tongues. Okay, and what will happen to the esophagus? This is important. There may be formation of esophageal web, and there is a disease which is known as Plummer-Vinson disease, also known as Patterson-Kelly syndrome. So Plummer-Vinson disease, Plummer-Vinson syndrome, or Patterson-Kelly syndrome. This can be seen in a patient of chronic iron deficiency anemia. What will be the clinical feature of this Plummer-Vinson syndrome? There will be a triad of chronic iron deficiency anemia, then there will be dysphagia, and there will be glossitis. Okay, so Plummer-Vinson syndrome, I am writing here. So there will be chronic anemia, there will be dysphagia, difficulty in swallowing solid food, and there will be one more thing, that is glossitis. Okay, inflammation of the tongue. So these three things are known as Plummer-Vinson syndrome. Okay, or glossitis. Okay, so one thing you may be asking, why will we have dysphagia? The reason is there will be formation of esophageal web. What is esophageal web? It is, there will be some inward protrusion of the inner wall of the esophagus, and if this was the esophagus, normal esophagus, but in case of Plummer-Vinson syndrome, the inner wall will protrude like this, and this in a web-like manner, and that usually happens due to desquamated epithelial tissue accumulation. That will result in dysphagia because the solid food particles will get stuck. They won't pass, but a soft particle or liquid particle will pass through. So that is Plummer-Vinson syndrome. Okay, so these are the common clinical features of iron deficiency anemia. The next thing that we have to know is how will we diagnose iron deficiency anemia. So we have to take blood, we have to collect blood, and we will have a lot of important findings in the patient's blood. Okay, so now we have to talk about the blood picture of iron deficiency anemia. Okay, first thing, I'm telling you the important points here. So the patient will be anemic, so hemoglobin will be less, no doubt. Then we have to know the red cell indices. Can you recall what are the red cell indices? There are three things that indicate the situation of red cell, and those things are mean corpuscular volume, or MCV, mean corpuscular hemoglobin, MCH, mean corpuscular hemoglobin concentration. These three things are known as red cell indices. All will be decreased less than normal level in iron deficiency anemia. What will we see in the blood film? Okay, now this is important. what will we see in the blood film? First of all, we will see microcytic and hyperchromic red blood cells. Okay, so why microcytic? The reason is in iron deficiency anemia there is deficiency of iron, but our red blood cells are trying to maintain its biconcave circular shape, 1/3 central pallor. You know, a normal RBC, of course this thing will be red, so a normal RBC, if we can view from the top, then 2/3 is red and 1/3 is pale. Okay, this is the normal red blood cell. But what's happening when we are having this microcytic hyperchromic? The size of the cell is reducing, so it will be smaller, and hyperchromic. That means there is less hemoglobin, and that means the central pallor will increase. So RBC will look something like this. Okay, this thing will be red, this is pale, but this one is expanding. The central pallor will be expanding and the size of the RBC will be decreasing. So this is the most important finding of iron deficiency anemia in the peripheral blood film. The blood film will be microcytic hyperchromic. But always remember, there is 4 types of anemia where you can have this microcytic hyperchromic blood picture. They are iron deficiency anemia, sideroblastic anemia, anemia due to chronic disease, and thalassemia. Okay, so what else will we see in the blood film? There will be anisocytosis and poikilocytosis. Anisocytosis means variation in the size of the red blood cell. Poikilocytosis means variation in the shape of the RBC. And there will be some different types of RBC seen. For example, there may be target cell present which contains a central red dot, you know, in the center of the central pallor. And there may be some cells known as pencil shaped cell. They will be like this, long cells, pencil cells, target cells. There may be elliptical cells and so on. Okay, now one thing you have to remember, I am saying microcytic hyperchromic anemia and the RBCs will be microcytic and hyperchromic and the red cell indices will be lower than normal. But sometimes iron deficiency anemia may also have, the same person may also have vitamin B12 or folate deficiency. And remember, when we have vitamin B12 or folate deficiency, those things are needed for DNA synthesis, you know. So if there is less amount of vitamin B12 and folate, there will be less cell divisions, and usually we get larger RBC in those deficiency, megaloblastic anemia, you know. So there we have large RBC, and iron deficiency anemia we have small RBC. So if both iron deficiency and folate or vitamin B12 deficiency present simultaneously, those two opposite tendency may balance each other, and the cell of red blood cell in that case may even be normal. Okay, so the last thing about lab diagnosis is what will we see in the bone marrow. Okay, so in the bone marrow there is a term which is known as micronormal blastic erythropoiesis. That means we will see an increased number of normoblasts in the bone marrow, but they will be smaller than the normal size. The reason is there is not sufficient iron. Okay, another thing that we will see in the bone marrow is the cytoplasmic maturation. will be behind the nuclear maturation. Okay, so this is an important thing. Normally those things occur simultaneously. The cytoplasm matures and the nucleus matures in the same time, and ultimately the nucleus is removed from totally mature red blood cell. As we know, RBC has no nucleus. But in this case, the cytoplasmic maturation will be slower than the nuclear maturation. And since the problem here is in the RBC, in the hemoglobin, but there is no problem in white blood cell or platelets, so the other things, the granulopoiesis and megakaryopoiesis, which makes platelet and granulopoiesis makes WBC, those things will be normal. Okay, so one more thing, iron profile. You may also have to know this iron profile. In iron profile, all things will be decreased except the TIBC. That means the serum iron level will decrease, serum ferritin level will decrease, but the total iron binding capacity will increase. Okay, so the last thing to say about iron deficiency anemia is the treatment of iron deficiency anemia. So the treatment has two stages or two steps. The first thing is we have to treat the underlying cause of iron deficiency. That's number one. Okay, and the second thing is at the same time we have to take measures to increase the iron store. Okay, so how can we increase the iron store? We have to give the patient iron tablet. Okay, and the thing we usually give them is oral formulation of iron. We usually give them ferrous sulfate, about 200 milligrams. Okay, so I'm writing ferrous sulfate 200 milligram 3 times daily. For how long? For usually 4 to 10 weeks. In severe case, we may have to continue this thing longer, further, for 3 to 6 months. Okay, and the problem is some patients, they have difficulty in tolerating the oral preparation. For those patients, there is parenteral way. We can give both intramuscularly or intravenously. Okay, so this is in short about iron deficiency anemia. I hope you go through your textbooks and look at different images and flowcharts to know more. So that's all for today. Take care.